and welcome to the National Kidney Foundation's Life as a Nephrology Professional podcast, where we explore research and innovation in kidney healthcare. I'm your host, Osama El-Shami. In today's episode, we will discuss a topic that has long been bothering me as a nephrologist and provider. Normally, when we see patients in clinic, we love having answers and definitive treatments. This helps us reassure our patients and provide hope for a brighter tomorrow. Fortunately, we have seen forward strides being made in one such case, IgA nephropathy. And while it is lagging behind, FSGS is hopefully next in focus. Today, we want to shed some light on the patient experience going through this journey, understand the pathophysiology of both IgA and FSGS, as well as explore recent advancements in clinical trials addressing both diseases. Before we begin, I'd like to acknowledge that today's episode is sponsored and developed in collaboration with Travere Therapeutics. The opinions presented are those of our individual panelists and not those of Travere or the NKF. Please join me in welcoming our guest panelists for today's episode.
Hello, I'm Anna Gaddy. I am a nephrologist at the Medical College of Wisconsin.
Hello, I'm Alicia Shelton. I'm a PA at Texas Kidney Institute in Dallas, Texas.
My name is Michael Phillips. I am a national kidney advocate. Been one for the last 7 years. I joined while I was on dialysis.
All right. Thank you all, and thanks for joining us for today's conversation. Anna, I want to start with you. It feels like for some time, IgA nephropathy treatment and research was kind of in a little bit of a hiatus, almost like a forgotten disease. Now, every time I attend a nephrology conference, and oftentimes even when I check my email, I see these updated treatment guidelines, new medications being pitched and discussed in different studies. What happened? What is driving this resurgence of interest in IgA nephropathy?
Yeah, that's a great question. I feel the same way. I graduated fellowship in 2021, and in 2021, it was pretty easy to know kind of what to do when you had a patient, and there weren't great options, and so you just kind of did your best. And then I felt like in the next 2 years, it was every single time I opened a journal, there was a new ad, or you go to a conference and there's new banners up, and I kind of checked out initially at first. So I was like, everyone just tell me once we've decided what the best thing to do is, and it took me a little while to kind of engage because it's overwhelming. So there's a couple of things that I think have really, as I have sort of learned more about this, there's a couple of things that have really made a huge difference. And one of them is that we've really done a great job as a nephrology community through the Kidney Health Initiative, which was this partnership between the FDA and the American Society of Nephrology that a few years back said, look, kidney disease is really important. And at the rate we're going, at the rate that people are, developing kidney disease, needing dialysis, and our treatments are being produced, we're just not making headway enough. And so how can we kind of tackle this so that our patients actually have options? And so the result of that initiative has been a lot of really great cooperation, trying to get, both disease state work being done and also try to come up with some pharmacologic options for patients. And so one of the big things in this space that's really made a huge difference is that we're able to use urine protein creatinine now as a surrogate endpoint rather than waiting for the reduction in GFR. And that's something that is really important across, a lot of different disease points. As nephrologists, I think, we all know that by the time someone's GFR starts to drop from a proteinuric disease, like you've really missed the boat. And so, and that takes years. And so waiting for clinical trials when you've got a patient who, you're saying, well, hopefully in 10 years, we'll have a trial for this. I mean, that's heartbreaking. And that makes the difference between someone, needing dialysis or having a good outcome. And so having that surrogate endpoint for clinical trials be accepted is really huge. And so that's been, I think, the biggest thing that's allowed us to see all this work. And so there's been also a lot of disease state work being done with IgA. So we now have identified, a lot of pathways that we can target with different therapeutics. And then also those therapeutics are able to be approved earlier. So now we've got lots of options, which is wonderful. And I think really kind of shows how important that systems or advocacy or cooperation really is. It's not just, if you have a good scientific idea, it will materialize. There's a lot of practicalities in there too, and those make a big difference. So that's number one. And then number two is that we've gotten really smart about the way clinical trials are done. And I think Dr. Hito Heerspink, if you caught at Kidney Week last year, gave a state-of-the-art lecture on creative trial design and how we can use trial design to overcome some of these problems. If you think about IgA or if you think about FSGS, these are not problems that, the bulk of my patients in my clinic, I'm sort of a general nephrologist, and most of my patients don't have these problems. And so recruiting for clinical trials is very difficult. You've got to have patients that are exactly, the right comorbidities, don't have anything else going on, are willing to be in a clinical trial, all this stuff. And so the PROTECT trial, I think, was a really nice example of how creative trial design can really make the best use of a cohort of patients. And I'm not going to get into the details of that, but it's really interesting how that trial was designed, and the open label extension was designed as well. And we're seeing that being done more and more with different medications, especially in this kind of rare disease space. So I think we're getting smarter about how we're doing trials, and we're also getting better at cooperating with regulatory agencies and really coming at it from a place of how can we say yes to options for patients. I say we very royally, but it's been really wonderful to see that across all different diseases, truly.
Fascinating and really encouraging, kind of seeing those avenues opening up for us to better take care of our patients, right? And design our studies in a better way and cut some of that red tape as well. Now, Alicia, I want to take a step back. Can we talk a little bit about the pathophysiology of IgA nephropathy? I kind of want to understand how it causes kidney damage, of course, and how does that guide the innovation and treatment formulation strategies that we may have? And, to build upon that, not to add too much to your plate, but also what pathophysiologic targets do we aim for then when treating IgA nephropathy?
Oh, I completely agree. I think understanding the pathophysiology of IgA nephropathy has been quintessential in identifying potential targets for treatments, for our treatment strategies, as well as opening doors for more clinical trials and options of potential therapies. IgAN pathophysiology is thought to be this multi-hit hypothesis. You're going to start with a first hit that's usually a stressor of the mucosal system of a genetically predisposition patient, and it leads to an immune response that then increases our B cell activation. This in turn leads to an increased production of galactose-deficient IgA1 in our circulation. This increased galactose-deficient IgA1 then sets the stage for the second hit, the formation of autoantibodies against galactose-deficient IgA1. The combination of these first two hits then contributes to what we call the hit 3, which is the circulating immune complexes. And these immune complexes then deposit in the kidney, and that's where the hit 4 occurs in the pathway and results in an immune response activating our complement system. As we know, the complement system leads to glomerular inflammation and injury. And then this injury then also leads where we see patients with IgA nephropathy having higher levels of angiotensin 2 and also increased levels of endothelin 1, which is both are potent vasoconstrictors. So increases in these peptides then causes a cascade of changes in our kidneys that leads to vasoconstriction, reduced blood flow, inflammation, injury, and ultimately fibrosis that we see. So understanding this multi-hit hypothesis has allowed the development of new and emerging treatments just based on those different levels. For instance, up at the hit 1, we have new clinical trials and recent clinical trials coming out looking at B cell directed therapies in order to inhibit that activation of the B cell. Also, there have been more advancements further down the line looking at the complement system, where we have some promising data in some of the clinical trials looking at inhibition of the alternative pathway, helping to reduce the inflammation and injury to the kidney as well. As previously mentioned, we've had in our arsenal the renin-angiotensin blockades. We've been using ACEs and ARBs for quite some time at helping reduce angiotensin 2 level, and they've been very beneficial in reducing proteinuria in our IgA nephropathy patients. But more recent clinical trials are now looking more at endothelin 1 and the use of endothelin A receptor antagonists. So it's really kind of an exciting time to see all these different parts of the pathway being utilized. So hopefully we can come together and maybe in the future even have multiple pathways and multiple ways to try to help our IgA nephropathy patients. Currently, we only have a handful of approved FDA therapies for IgA nephropathy. One of those is being sparsentan. It's a dual endothelin and angiotensin receptor antagonist, which is quite interesting because it's working on two of the pathways, if you think about it. And it targets the podocyte at both the endothelin A receptor as well as the angiotensin 2 subtype 1 receptor. Data from the phase 3 PROTECT study was a comparison looking at sparsentan versus irbesartan in adults with biopsy-proven IgA nephropathy. And so what they noted in that trial was a clinically significant improvement in the proteinuria as well as reduction in the decline of the eGFR. As Dr. Gaddy mentioned earlier, that's been a really big milestone for us is the reduction of proteinuria. Like she mentioned, we don't always see that decline in the eGFR until later on. So those earlier outcomes of seeing the protein reduce within a patient with IgA is very beneficial. In the PROTECT trial, they did see that sparsentan treated patients had about a 43% reduction in proteinuria compared to irbesartan patients, who their UPCR overall remained relatively stable from baseline. Additionally, when talking about that eGFR change of slope, looking at their 2-year follow-up data, it was noticed that sparsentan had about a 2.7 reduction in the eGFR compared to those on irbesartan, who their eGFR had lowered 3.8 ml per minute. Overall, it's just, like I said, an exciting time to see these new drugs coming out in different pathways for us to be able to hopefully be able to treat our patients. The landscape of IgA treatment is changing every day. There's a lot of phase 3 and phase 2 trials still out there. So it'll be interesting to see what all comes through fruition for us with IgA nephropathy.
Yeah, no, it's fascinating. Hearing about the 4-hit, model and being able to target multiple hits at the same time using one drug sounds like, a dream scenario and a very promising path. Because, I think, and, Anna, correct me if I'm wrong, but for the longest time, really our main focus was, the proteinuria, but getting a drug potentially that can help both proteinuria and reducing the rate of decline of kidney function, right, in the eGFR is kind of a dream scenario for us, right?
Absolutely. And I think we're still, now that we have a menu, for the longest time, we were just starving. And so anything sounded good. And now that we have kind of this menu, we have to start thinking about our strategy of how we're going to reach for these things and when we're going to reach for what. And, that's something that it can be really intimidating. I think if it was just one thing, we would know when to use that. But we have to start thinking about what things to reach for when. And I think some of the analyses of the radar data has been really helpful. For those that don't know, it's a database of rare disease outcomes with biopsy data and longitudinal data that's out of the UK. I think that's the data from that database has really helped us kind of see what the natural progression a lot of these diseases are. And so some very, very smart people in this space have really done some great work trying to think about when we might use these different drugs and then have created trials that really address those questions. So we don't wind up with trials that don't really address our question, which is the best drug for my patient, the one in front of me and all of their unique, things about their disease that's been unique. So its options are great. And then knowing how to use them is always a problem of having lots of options, but I will take that any day over, not having any options. So.
No, absolutely. Being able to target it pharmacologically is very important for us and for our patients. Now, speaking of patients, another glomerulonephropathy that has a similarly unmet need for treatment and innovation really in our space is FSGS. And I remember when I was a fellow, really, the gist of our interactions with FSGS patients, counseling and treatment was mainly RAS inhibition, weight loss, and for the most part, monitoring, right? So we're kind of praying and hoping that the maximum dose of the RAS is going to achieve what we need to in terms of slowing things down and the rate of progression. Now, Michael, FSGS appears to be the forgotten GN. From a patient's perspective, what were some of the signs and symptoms that you experienced and that a patient in general should be looking out for in terms of symptoms of FSGS?
Well, I started seeing myself gaining weight and retaining fluid, but I had no idea what it was until I was sent to a nephrologist and they did a biopsy, and that's how I found out about it. And it was kind of scary because I think I was as far as I know, even to this day, I'm the only person in my family that had kidney issues and didn't know where it came from.
And how was that conversation then with the nephrologist after you had done the biopsy and they came back and told you have FSGS? How was that information presented to you?
Well, I experienced, because I found out while I lived in Dallas for a while, and I moved back to Chicago. And while I was in Dallas, my nephrologist was like, everything is getting better, so you should not ever have to go on dialysis. But 6 months being back in my hometown of Chicago, I ended up having to go on dialysis. And I was instructed to go and find a transplant, to go call a transplant center. I was in denial for a while because I was like, I'm not doing that. And I didn't do it for about 6 more months before I contacted a transplant center.
That's understandable, right? So something kind of hits you out of nowhere. Now you're diagnosed with this kidney disease. We don't have an explanation for why it happened, how it happened. There's nobody else in your family that has anything like this. And all of a sudden now you're starting this dialysis journey and being instructed to go find an alternative kidney, basically, right, for a kidney transplant. So I think that's, completely understandable. And, something that even for us as nephrologists is a difficult conversation to have with our patients because we can't really blame one thing per se, right? And we're grasping for answers. Now, Anna, what is the prevalence of FSGS, right? And, we talk about FSGS, we talk about IgA, but how are they different from each other, really?
That's a big question. I think the most important thing to understand is that FSGS, and again, I know a lot of our listeners will know this, but FSGS, when we talk about FSGS, again, it's a pattern of injury. It's almost like I'm saying there's a bruise on your leg. IgA nephropathy, I'm saying you got kicked and now there's a bruise on your leg. And we know more about why the kicking happened and how exactly the foot connected with your leg. And so we can kind of block all those steps, right? FSGS, all we're doing is saying, I don't know, man, you're bruised, right? And so there could be a lot of different ways you might have hit something. And truly, like it's an apt analogy because there are a lot of things that can lead to FSGS. And we know this. We know there are some people who are born very low birth weight or who are very, very heavy or maybe only have one kidney. And so their kidney's under a lot of stress. They can develop a picture of FSGS where some parts of the glomerulus are affected and other parts aren't. But then we've got patients who, are healthy patients who out of nowhere maybe get COVID or, an illness, or maybe nothing happens. And out of nowhere, they just sort of start to have this really rapid decline in kidney function. And when we take a look, it looks like, someone kicked them, basically. They have this pattern, but we don't know what caused it. And so, that's very different than IgA. I don't know that it's a whole lot different than IgA used to be 20 years ago when we didn't know as much. But I think the huge difference right now is that we don't know a ton about FSGS and we don't have lots of ways to treat it because we don't know what causes it. And so how can you know how to help if you don't know what caused it? So, but from an epidemiologic standpoint, like FSGS is responsible for almost half of the cases of nephrotic syndrome. So things like Michael described with swelling, gaining weight, maybe foamy urine, that sort of thing. But it's pretty rare. So it's like 7 out of 100,000 patients or people, not patients, get FSGS. But there's, like I said, a huge variety in what those patients are like. So patients that do have really severe disease are much more likely to be African American or have African heritage. And we know that is primarily because, or maybe not primarily, but a lot of that is because of that APOL1 allele that we have learned a lot more about. that confer some resistance to parasitic infections in the areas where those alleles sort of became prevalent. But now, over thousands of years, that protective effect is sort of outpaced by the fact that it predisposes your glomeruli to collapse when you're under some sort of stress that we really don't understand very well. We also understand a lot more about now the circulating permeability factors, or like cytokines or sort of circulating chemicals that basically cause the foot processes of your glomeruli to efface and then cause that proteinuria. So we're learning a lot more about it, but I think over the next 5 to 10 years, we'll probably describe FSGS a lot differently than we do now. And so hopefully that will come with similar improvements in pharmacotherapeutics and in options. So one big, difference is that primarily FSGS affects, the very severe cases primarily affect our patients with African heritage. So that's one very difficult thing. And then another very difficult thing is that these patients tend to have really, really bad clinical courses. It's a disease that when you send your patient for a biopsy and this is what comes back, you kind of have that sigh of, knowing that it's probably not going to end well. And not just because of lack of therapeutics. Sometimes we try steroids, but they're just not good therapeutics yet. So there's really a need here. And it's a disease that I can imagine would be confer a lot of hopelessness if that's the diagnosis you receive. And another really tough thing about FSGS is that it can, of course, recur in transplants, sometimes really rapidly. And so that's very scary as well. So, there's a lot of differences on a cellular level or on a molecular level, some of which we know, some of which we don't know. But in epidemiology and options, they're also very different. So both cause proteinuria, but other than that, there's not a whole lot of similarities in terms of the presentation or who it affects or those sorts of things. So.
Yeah, no, absolutely. And I really love that example that you gave with the bruising and the kicking. I think that's spot on.
Did you like that? I just came up with that. Yeah. No, but it's true. It's like, it's basically saying I don't know, but fancier.
All right, Alicia, I'm going to turn to you for some hope. Okay. What work has been done so far in order to help investigate potential treatment strategies for FSGS then for our patients?
It all kind of began with the Kidney Health Initiative in 2019, that along with an international collaboration, it's called the Parasol Work Group. They really were looking for important insights, analyzing data to get important insights for us on our management of FSGS, and particularly in relation to proteinuria and eGFR as our biomarkers and our outcomes, our endpoints in the treatment of our patients. They just recently released some results at ASN Kidney Week in last October, and their analysis was looking at over 1,600 pediatric and adult patients. And what they found in that analysis was that proteinuria reduction is strongly associated with a reduced risk of kidney failure. This suggests that proteinuria should be regarded as one of our big endpoints whenever we're looking at our patients with FSGS and reducing that proteinuria. But what they also proposed during their analysis was that certain proteinuria thresholds that we should be trying to strive for in the treatment process. And that would be a reduction of 50% of the proteinuria within a 3 to 6 months of therapy whenever seeing a patient. Like Dr. Gaddy mentioned earlier, even with IgAN, when we were speaking on that, it is more important to start early and get that treatment going sooner and get the proteinuria down to help our patients with better outcomes in the long term. I think it's going to be an important implication in our clinical practice. I think we're going to start using it more to see if the treatment options that we can use and what we're trying, if they're really working for our patients and are going to benefit us with our patients. As we just talked about with IgA nephropathy, we've seen increasing clinical trials in FSGS as well too, both looking at the initial onset of FSGS and treating those patients, as well as even some studies coming out for post-transplant recurrence as well. There's currently no FDA approved treatments for FSGS, but we do have these multiple ongoing trials, and we've seen some interesting data in some of these trials, including some that we've seen with sparsentan with the DUET and DUPLEX trials. Looking at the DUET trial, it was a phase 2 study looking at the efficacy between sparsentan and irbesartan. And what we did see is that at 8 weeks, there was a significant reduction in the UPCR, the patients on sparsentan. We saw about a 45% reduction in their proteinuria as compared to those on irbesartan, where we only saw about a 19% reduction. Additionally, the FSG partial remission endpoint for that study was also reached at 28% for those patients on sparsentan, as compared to only 9% on the irbesartan arm of that study. That has led them into doing a phase 3 trial, which is the duplex trial. It was also looking at patients with biopsy-proven FSGS, looking at the use of sparsentan or irbesartan in comparison. And what they found at about 300 patients, about a little over 350 patients were in that study and for 108 weeks. And although at the end of that, duplex did not achieve its primary endpoint, which was looking at that eGFR slope, they did meet their proteinuria reduction that was pretty significant, with 50% noticed in the patients on the sparsentan arm as compared to 32% on the irbesartan arm. And as we talked about with the parasol group, it's very important to lower that proteinuria effectively. And so meeting that 50% threshold is really important in these trials. They also noticed that more than 2 times greater, there's a 2 times greater complete remission rate on sparsentan than there was on irbesartan, about 18% compared to 7%. So it's really encouraging data out there looking at possible future treatments for FSGS, but still at this point, nothing's been approved by the FDA. We don't have anything to use in our arsenal of weapons against FSGS, but it's very optimistic in the future that we're going to have some drugs be coming out that are going to help us with our treatment and improving outcomes with our FSGS patients.
But yeah, so Alicia, that's such an interesting, I remember exactly where I was because I remember Michelle Rowe, who I'm a huge fan of, presenting this data at Kidney Week. But I remember everyone saying, oh yeah, like it was a negative trial. And, you know, we say all the time in science that there's really no such thing as a negative trial if you design your trial well. And I think that with the duplex trial, didn't meet its primary endpoint of GFR decline. I think there were so many lessons that we could learn from that. One is that still a significant reduction in proteinuria, obviously, but again, that maybe we shouldn't be expecting to see that GFR decline is going to be evident so quickly, even if a drug does reduce proteinuria. And so I think it just kind of highlights for us as we're coming, you know, the using proteinuria as an endpoint is so new, as I discussed kind of at the beginning. It's not something that we've been using as an endpoint for so long. And I think, you know, you could always do the ultimate trial and wait 50 years and see who ends up on dialysis and who doesn't. But as we try to bring drugs to market fast enough to actually treat patients and keep kicking it down the line to being like, you know, maybe in 20 years we can fix this. I think we have to it's an iterative process of figuring out what endpoints we really should be looking at. And so I think, you know, using some of the later trials of other drugs and other diseases have been looking at proteinuria first, and then also considering slope of eGFR as like a secondary or an exploratory endpoint is probably much more reasonable to do, you know, extensions to look at GFR because we know that endpoint by a ton of other disease processes is a good one. And so I think that we learned a lot, not just about the drug in question with that trial, but also about the endpoint across the board, so I think there was a lot of good takeaways from that trial. So I'm really glad you pointed that out, because I heard a lot of people go, well, it's a negative trial. I'm like, well, I don't know that it was a negative trial. I think it was a trial that taught us a lot, maybe not what we thought it was going to teach us, but, you know, we're looking here for the truth, whatever that might be. And so I think that was a really cool trial for me. Of course, we still have to keep in mind that these are clinical trial results with emerging data, and we have to remember that sparsentan is not currently approved for the treatment of FSGS.
I think that's important information for us as clinicians to know, and it's really promising, at least, you know, some of the studies that we've covered where we see, you know, sparsentan outperforming irbesartan, and hopefully other studies will come out looking at other drugs and how they interact as well. And we talk about remission, we talk about proteinuria from a patient's perspective who has FSGS, right? And you needed a kidney transplant as a result. What are your biggest priorities when you're working with your healthcare team to make these various decisions related to your kidney health and treatment management?
I'm pretty much under a good team. All of my doctors go through my kidney doctor to see, hey, because I do suffer from high blood pressure, which was from what I was told was the cause of me getting FSGS. How can I get better? I didn't expect to ever have to have a transplant or organ transplant. I couldn't process that because it was overwhelming for a while. It was a challenging part of my life. During the time that I was on dialysis, I kept a personal journal and I published it on Facebook to share my journey being on dialysis.
Absolutely. I think, it's important to consider the care and expectations across the continuum of the kidney pathway, right? And unfortunately, right, for you, you got a taste of each one, right? You got that phase where you were diagnosed with the kidney disease, and then you had to deal with that phase of dialysis and what that entails. And then now, right, getting the kidney transplant and protecting, right, that kidney and organ that you have. And, I think it's important for us to think across that whole continuum. Now, I know we're running low on time, so I want to make sure that, I go around and ask really each one of our panelists today, starting with you, Anna, any final thoughts or message that you would like to share with us and the listeners?
I would say, my personal perspective is that when things seem overwhelming and there's a lot of new stuff coming out and you want to just sort of bury your head and wait for the guidelines to come out and someone to tell you what to do, I would say have another cup of coffee and devote a half a day to reading a nice review article on it, because it really is empowering to feel like you have some options. And I think when you can relay to your patients that, hey, I'm not exactly sure what is going on or what the right thing to do is, but here are all the new options, and here's what I'm thinking through, and here's why I'm thinking of it. It really gives you a sense of ownership. It gives them a sense of ownership, I think, over the course of things, and sharing that uncertainty with them. Patients can feel your uncertainty even if you aren't honest about it with them. And so I think that being as informed as you can be, and then sharing with your patients not just what you know, but what you don't know, and the road to how you're going to know more, is a really empowering thing, and has been for me. That's just kind of speaking from, my journey with coming to figure out all this new IgA stuff, but also I think anything in the future, just dig deep and figure it out, because it's going to be an exciting time, but it's not going to be an easy time for us also. So that's my advice.
Absolutely. Thank you for that. Alicia.
Yeah, just kind of to go on what Dr. Gatti was just mentioning. I think a lot of it is just going to be hopeful too. I think we've all, when we're treating these patients with IgAN or FSGS, we know how the outcomes can be, and we know as providers, it's kind of hard, like we've talked about before, telling them the outcomes that probably are going to happen when you're talking about possibly dialysis, transplant as well. I think it's a good time to be hopeful that we have a lot coming down the pipeline that will give us better treatment options, better ways to take care of these patients. And even if we're not able to start that progression all the way to get to dialysis or transplant, I'll be very hopeful that we're going to be able to really slow that down and give patients a better quality life for a longer amount of time.
Great. Michael, any word for our listeners from the patient perspective?
Well, I would say that as a patient, you have to be your own advocate. You have to ask questions. I was just so excited to see what options is available out there.
And with that, I would like to say a thank you to my guests for joining us today for this episode. I've learned so much today about both IgA nephropathy and FSGS, and I'm sure our listeners benefited a lot too. I want to also thank Michael for being such a powerful advocate for patients and hope that this episode serves as a sign that we as a medical community see you, we hear you, and we are here for you and all of our patients. I leave today's episodes hopeful for a future where we can tackle IgA nephropathy and FSGS head-on and have greater certainty and optimism to share with my patients both now and in the future. I'm Osama Al-Shami, and thank you for tuning into the Life as a Nephrology Professional podcast, where we explore best practices and foster a sense of camaraderie among the kidney health community. Until next time, may your practice be innovative and may your research be groundbreaking. Thank you.